Welcome commissioners. Welcome commissioners and members of the public. This meeting is a hybrid commission meeting. There are several commissioners right here in room 100, and the rest of the commissioners are participating via Zoom. Given that this is a hybrid meeting, additional ground rules will still apply. I will begin this meeting with a roll call of commissioners. During the meeting, I will ask that people speaking identify themselves before speaking, so we know commissioners and members of the public will know who's talking and have the same knowledge as those who are in room 100. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask that commissioners and presenters mute their electronic device when they're not speaking. And as previously stated, MHCC posts documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We will continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. I will now call the roll. Commissioner Boyle.
I'm here.
Commissioner Brumbach. Commissioner Brzezinski.
Here.
Commissioner Cheatham.
Here.
Commissioner Dorden.
Here.
Commissioner Jensen.
Here.
Good to see you, sir. Commissioner Metz. Commissioner O'Connor.
Here.
Commissioner O'Grady.
Here.
And Commissioner Ojikutu.
Here.
Fantastic.
You missed me, Commissioner Bandari here.
Did I miss you? I'm so sorry, Dr. Bandari.
Thank
Glad you're
you.
here.
It's 5 to 10 pages. Every source.
All right, we'll move to agenda number 1, the approval of minutes. Included in your packets are copies of the minutes from the September 15th, 2022 public meeting of the commission that took place in person and by video conference. I will now entertain a motion to approve the minutes of the September 15th, 2022 commission meeting. Do I have a motion to approve?
Motion to
And
approve.
Commissioner Brzezinski, do I have a second?
writing.
Commissioner Boyle. All right, any discussion?
Week. And I got beat. She been writing her paper like 6 weeks.
I can hear somebody's phone. If you would kindly mute your phone, that'd be fantastic. Thank you.
Right, how did
All
you
right.
do that? Like, I'm a criminal
All in
justice
favor
right on.
of the motion to approve the minutes?
Aye.
Any opposed?
Aye.
No one opposed. All right. Thank you very much. We've approved the minutes. On to agenda number 2. We are changing the agenda slightly and moving up the action on certificate of need for Pyramid Healthcare. The next item on the agenda is this recommended decision in the matter of the certificate of need application of Pyramid Healthcare Incorporated to establish an alcoholism and drug abuse intermediate care facility in Prince George's County, docket number 22-16-2452. Commissioner Mark Jensen served as a reviewer in this matter and issued a recommended decision to grant the certificate of need application with 3 conditions. The applicant Pyramid filed exceptions to the recommended decision, which were subsequently withdrawn after Commissioner Jensen revised one of the conditions. The interested party, Luminous Health Pathways Incorporated, did not file exceptions nor respond to the applicant's exceptions. Because all exceptions have been withdrawn, there will be no exceptions hearing today. The reviewer, Commissioner Jensen, will present his recommended decision. I will then entertain a motion on this agenda item and open the floor for discussion and then a vote. As a reminder, the commission may approve the application with conditions, or deny the application. Commissioner Jensen, whenever you're ready, would you please present your recommended decision?
All right. Well, thank you, Acting Chair Wang and fellow commissioners. Can you all hear me?
Yes.
All right. You have received my recommended decision, which details the rationale for my recommendation that the commission conditionally approve Pyramid Healthcare's application for a certificate of need to establish a Track 2 50-bed alcohol and drug treatment intermediate care facility in Prince George's County. I'd like to provide you with background about the project and history of my review. Pyramid background. Pyramid Healthcare, Inc. is a for-profit company that operates over 80 inpatient and outpatient facilities in Pennsylvania, New Jersey, North Carolina, Georgia, and Maryland. Pyramid Healthcare is the 100% owner of Pyramid Walden LLC, which currently operates several facilities in Maryland and will operate the proposed facility. Pyramid Walden currently operates a 52-bed ICF and the 16-bed residential facility for substance abuse disorder in St. Mary's County, a 64-bed ICF in Harford County,
Hello?
and 3 outpatient facilities in St. Mary's and Charles counties.
Hello? Yeah, hi.
The project, Pyramid proposes to establish a
Oh, it's not for
100-bed
sale.
facility, which will include 50 intermediate care beds and 50 beds providing clinically managed high-intensity residential services. Intermediate care is a level of substance abuse treatment in which patients receive medically monitored intensive inpatient services. A certificate of need is required to establish intermediate care services, but not needed for lower levels of substance abuse treatment. Pyramid's proposed ICF is a 2-track facility, meaning that Pyramid has committed to reserving at least 50% of its bed capacity for indigent and gray area patients. Pyramid's proposed facility will only serve adults and will be located at 3000 Lotsford Vista Road in Bowie, Maryland. Pyramid proposes to convert a 1-story building that formerly housed the Developmental Disability Program to establish the ICF. The project will renovate 26,843 square feet of the existing building space and add 6,797 square feet of new construction, with completion projected by early 2023. The total cost of the project, including both intermediate care and residential services, is estimated at $9,861,800. The regulated ICF component is estimated to cost $4,930,900. Pyramid plans to fund the project with $2.5 million in cash and $7.4 million in loans. Luminous Health Pathways, Inc. sought and was granted interested party status because it is authorized to provide the same services as Pyramid in a contiguous planning region. Pathways submitted comments on Pyramid's application, urging the commission to deny Pyramid a CON. Specifically, Pathways stated that the applicant failed to demonstrate that the project is needed or financially viable. Pathways also argued that the project would have a detrimental impact on existing providers and on the healthcare delivery system. Although Pathways did not file exceptions to my recommended decision, I do want to briefly address the concerns raised in its comments. At the core of most of Pathways' comments is the argument that Pyramid's use of a 20.1 day average length of stay in its need analysis was inappropriate. Pathways argued that Pyramid should have used instead a 14-day average length of stay based on the need methodology for private pay beds in the state health plan. Pathways argued that the use of a longer length of stay inflated the need for additional intermediate care beds and the financial viability of the project. Further, Pathways argued that a 20-day average length of stay would have a negative financial impact on the healthcare delivery system. Pathways also argued that the internal data that Pyramid used to calculate need for its project was unreliable, that Pyramid underestimated the cost for staffing, and failed to conduct a thorough analysis of the impact of the proposed project on other providers. Lastly, Pathways contended that the proposed project's use of triple occupancy rooms would have a negative impact on the care of Pyramid's vulnerable low-income clients, noting that most private pay ICFs have at most double occupancy rooms. I want to pause there for just a moment. If somebody's got a phone or something going on in the background, if folks could mute themselves, that'd be great. Now, my analysis, while I appreciate the concerns raised by Pathways, I've determined that Pyramid satisfied all of the state health plan standards and the criteria for review. Pyramid provided ample justification for its use of a 20.1 day average length of stay based both on its own experience at its other intermediate care facilities, as well as statewide averages reported by the Maryland Department of Health. I also found that Pyramid's use of internal data of the number of patients turned away from its other facilities was a credible and acceptable proxy for assessing needs. And importantly to me, there's no prescribed need methodology in the state health plan for track 2 facilities, leaving it up to the applicant to put forth a reasonable basis for establishing need. I find that Pyramid's approach establishes a reasonable basis for need. Pyramid is an established organization with existing experience providing intermediate care and is affiliated with a larger organization that brings a scale of assets and operation. This provided me with a greater level of confidence that the project will succeed if more difficult market conditions develop in the future. While semi-private rooms might be preferable, multiple bedrooms are still common in Maryland in both Track 1 and Track 2 facilities. Given the need I found for Track 2 ICF beds, I do not believe that this project would have a substantial impact on existing providers, and I believe it would have a positive impact on the availability and accessibility of ICF services for low-income patients who are in need of these services. For the reasons further detailed in my recommended decision and my October 7th, 2022 letter to the parties, I recommend that the commission approve Pyramid's application for a CON with the following 3 conditions. 1, prior to first use approval, Pyramid shall document that it has posted a statement of charges and information regarding the range and types of its services online and in a prominent place in the registration area, and shall also provide a copy of the document with this information that it will provide to the public upon request. 2, prior to first use approval, Pyramid shall provide proof of preliminary accreditation of its Bowie, Maryland facility by the Commission on the Accreditation of Rehabilitation Facilities or another accrediting body approved by the Maryland Department of Health, and must timely receive final accreditation by CARF or another approved accrediting body. And 3, Pyramid shall notify the Commission and the Behavioral Health Administration in writing within 15 days after it receives notice that its accreditation has been revoked or suspended, or should it lose its state license. If its accreditation has been revoked or suspended for reasons related to health or safety, or it loses its state license, Pyramid shall cease operation until the Behavioral Health Administration notifies the Commission that the deficiencies have been corrected. These 3 conditions formalize requirements that are written into the state health plan for all intermediate care facilities. Pyramid initially accepted to a prior version of the 3rd condition. However, after I revised the 3rd condition in consultation with the Behavioral Health Administration, Pyramid withdrew its exceptions. This concludes my initial remarks. I'm happy to answer any questions my fellow commissioners may have.
Thank you so much, Commissioner Jensen. Appreciate you being here today. I'd like to invite counsel for Pyramid Healthcare to introduce the party representatives in attendance today.
Thank you very much. I am here together with my colleague Allison Ludich as counsel for Pyramid, and with us on behalf of Pyramid are Jonathan Wolf, President and CEO of Pyramid Healthcare, Inc., and Brandon Golder, Vice President of Development and Strategy for Pyramid Healthcare, Inc.
Fantastic. Welcome to our meeting.
Thank you.
Thanks for having us.
Would any commissioner like to make a motion to adopt the commission's decision on the certificate of need application?
Motion.
Thank you, Commissioner Bazinski. Do I have a second?
Second and Boyer.
Thank you, Commissioner Boyle. Thank you, Commissioner Boyer. We got a great tag team going here. It's be very efficient today. All righty. Well, it's seconded. It's open for discussion from the commissioners. Is there any discussion on the decision?
This is Commissioner Bandari. I have a question for Ben or Mr. Jensen. So you said it's in a much needed area. In such projects, is there any, they have allocate any certain resources for underinsured or uninsured patients? Is there any charitable commitment in such projects or not?
I would, well, I would ask staff, to correct me if I'm wrong, but I believe that the 50 bed for gray and indigent encompasses that care.
That's correct. Commissioner Jensen's absolutely correct. Under our state health plan for acute inpatient drug treatment, we have two categories of entities. Track 1, which is typically a facilities that provide drug treatment care for heavily insured or individuals who can self-pay. Track 2, which this is one of those facilities, agrees to take Medicaid and gray area patients. And so to your question, Dr. Bandari, yes, they are well positioned to treat those populations, we believe.
Thank you.
Are there any further questions? Yes, Commissioner Boyle.
I certainly approve this. I just would like a little bit more background on the change on the third condition.
Absolutely. I'll address it at least at a high level, and then I can be, that can be corrected or supplemented by staff. But essentially, while this third condition is in the Maryland State Health Plan, it has not previously been included in all applications for ICF facilities. Number one, that issue was raised. Number two, it previously said that if they lost the accreditation, if the accreditation had been revoked or suspended, that they immediately had to cease operations. And it was pointed out that there are situations in which that could be suspended, but the Behavioral Health Administration would still recommend the facility stay open. So in response to the first issue, we said, well, it's in the state health plan, and perhaps it hasn't been in all CONs previously, but it's going to be in all CONs going forward. So that addresses that issue. The second issue was addressed by coordinating with the Behavioral Health Administration on better language, so that it wouldn't require them to cease operations on a suspension if the Behavioral Health Administration was willing to continue working with him, unless it related to health or safety of the patients. So it was fine tuning the third exception so that it complied more precisely with the oversight of the Behavioral Health Administration.
Great. Is there any further discussion from commissioners? No? All right. Thank you, Commissioner Jensen. In that case, do I have a motion to approve the certificate of need for the recommended decision in the matter of the establishment of an alcoholism and drug abuse intermediate care facility for Pyramid Healthcare Incorporated? We did? Okay. All righty. All approved? All in favor?
Aye.
Anybody
Aye.
opposed?
Aye.
No one's opposed? Fantastic.
Right.
You have your certificate of need. Thank you very much.
Thank you. And Chair, may I just request Pyramid would like to just state a brief word, if it may?
Please.
Yeah, this is Jonathan Wolf. I'm the CEO of Pyramid, and I just want to thank the commissioners for the positive decision today. We look forward to providing this much needed service to Prince George's and surrounding counties. So thank you very much. Appreciate it.
Thank you very much. All right. Moving on to agenda item number 3, the update of activities. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Does the executive director have any updates?
I have
Oh,
a question.
please, Commissioner Boyle.
This is something I do every time, but I would like to point out the acquisition issue of another comprehensive care facility that would likely not receive a CON if they were applying rather than purchasing. And I would like future for the commissioners and staff to discuss this a little more in depth about what possible steps that we could take to improve the situation.
Thank you, Commissioner.
So noted. Yes.
Mr. Executive Director.
So thank you, Acting Chair, Commissioner Wang. Just a few things I wanted to talk about today. First item is just related to the information that I shared with you earlier this week regarding some challenges to the total cost of care model in 2022. I think the information that HSCRC provided to stakeholders regarding the status of savings for this year is something that we will not only be paying attention to in our CON processes moving forward, but we'll look forward to working with our partners across the way, HSCRC, in devising potential solutions to the challenges on the model. As of this point, nothing has been finalized in terms of the state's response. What HSCRC did is alert hospitals and others that in 2022, we may not meet all of the benchmarks that were agreed to in the total cost of care agreement. We do have some options. One that is appealing is to invoke the exogenous factor clause in the demonstration agreement, which would, if accepted by CMS, allow state to not meet the thresholds on total cost of care savings for this year. That type of permission, an exogenous factor that a state could not have accounted for has been invoked, I believe, in Vermont and in the rural health model that exists in Pennsylvania previously. This has not been formally presented to CMS, so we have no indication on their reaction to it. It is also possible that HSCRC would move forward with some rate reductions affecting hospitals. It's notable that the Maryland Hospital Association did propose some modest reductions in hospital rates, specifically for Medicare charges. That would shave Medicare charges by about $25 to $26 million. That has not been accepted, but it would have the consequence of raising the differential between what Medicaid is paid and what the private sector is paid from about a 7.5% reduction for Medicare to an 8.5% reduction for Medicare, which would be further constraining the all-payer nature of our model that has existed for more than 3 decades. That is, that all payers pay the same rates. So that's not without some short-term consequences. We don't have any firm resolution at this point. And it's also, I think, important to note that we still have some part of 2022 to elapse. It is, as HSCRC pointed out, remarkable that Medicare spending nationally, while forecasted by the Office of the Actuary to be running at about a 7.1% rate, when actually in reality over the first 6 or 7 months of 2022, it's only a bit under 2%. So that is one factor in why our savings challenges are so great, that we relied on the Office of the Actuary in setting hospital rates at the start of 2022. It has not panned out nationally Typically in high inflation periods, one would expect healthcare spending to be running apace or even above the inflation rate, but that's turned out not to be true for Medicare. Illustrative, I think, of the peculiar situation the country is, with responding to both the COVID-19 challenges as well as a period of relatively rapid price escalation across all healthcare inputs at this point. So more to come on this. Obviously, as we consider certificates of needs for the applications for hospitals, this will be something we have to pay attention to. As some of you may recall, in the last session of the legislature passed and the governor signed House Bill 1148 that permitted insurance companies to offer two-sided risk programs in the state that would enable provider groups to do well if they delivered high quality, lower cost care, and potentially pay a penalty if they did not. As part of that legislation, we were directed to collect data from insurance companies on the cost efficiency and quality of these programs. We've worked over the last several months with one of our contractors to derive a template for collecting that information. We have presented it to payers individually, as well as to in a group. We have encountered some resistance to the data collection template that we are proposing, but are confident we will be able, in the final analysis, work these issues out. I'm alerting you because we do plan to bring forward our recommendations on the data reporting formats next month that would apply in 2023. We're taking our obligations under 1148 seriously. And in developing that template, we looked very carefully at what's being done in the 5 other states that have similar requirements regarding collection of non-fee-based, what are called alternative payment system reward structures, and use those experiences as a guide. There's several additional factors we have to take into account in Maryland, because the legislature also asked us to gather some quality information that is really quite unique to Maryland, but we think consistent with the principles that have been laid out, not only in our overarching model, but also in models that have evolved and been permitted here in the past, that we are not interested only in cost savings, but also quality improvements. We'll keep you informed moving forward. We have presented it to our state partners, the Maryland Insurance Administration, the Maryland Health Benefit Exchange, the Medicaid Administration, our partners at HSCRC, the Primary Care Program, as well as the Prescription Drug Affordability Board. And they have encouraged us to, in many cases, to be even more ambitious in terms of what we collect. So it's very likely we will use some of their input as well as guides. Next week, we will be meeting with the provider community to brief them on our plans moving forward. They were the ones that asked the legislature to insert this provision in the bill to begin with. So our expectation is that they're going to be very insistent with us moving forward with a appropriate data collection effort. I also wanted to note that Kanye Strotman's team has worked aggressively over the last year and a half to get Kaiser Permanente to provide information on capitated and health facility information. As most of you know, Kaiser does not pay fee for service. They do not pay claims. They submit encounters to our all payer claim database. But as we try to benchmark total cost of care for the private market, the fact that we could not get pricing information from Kaiser was a major limitation. Kaiser's put forward its own resources to generate a methodology that will give us quasi priced encounters that we can then use to construct total cost of care estimates at the individual enrollee level. That's going to be most helpful for some of our work with our colleagues at HSCRC. And I wanted to recognize the work that Kaiser's put forward in this. We understand their argument that this is not the way claim transactions are paid under the Kaiser model, but we do need to have a proxy to generate total cost of care estimates at the patient level in order to meet our other requirements. I also wanted to note earlier this year, Chair Sargent did ask commissioners to serve on work groups, particularly work groups not convened by the Healthcare Commission. Dr. Bandari is serving on the Workforce Crisis Commission that was established in legislation passed in this past session. He is serving as our representative, supported by Sade Paul. His presence there has provided us with an important perspective, and we look forward to working closely with him moving forward. It's clear the commission is counting on the Healthcare Commission to provide some important input, particularly on how data collection to measure workforce challenges as we move forward. I would note that I suspect that the workforce crisis will be a continuing issue that the legislature will try to address in 2023. A couple other notes just in terms of other work groups that are convened by the commission. Our palliative care work group, which is requires us to look at approaches to expand coverage for palliative care services, got underway last month and will continue to meet next month with the aim of producing a report to the legislature in the fall of 2023. That's continuing. And we'll also launch a small assisted living facility assessment work group that's to provide recommendations to the legislature on ways, new approaches to regulating small assisted living facilities with 9 beds or less. A quick exam here on, we have about 1,600 assisted living facilities. Only about 350 are 10 beds or more. Most, the vast majority are small. The regulatory framework for ensuring appropriate care is still is delivered is challenging given the nature of these facilities. I think the legislature is looking for new approaches that would both provide assurances to families that quality care is available, while also not proving overly burdensome to small organizations. I think that's going to be kind of challenging. We don't have any representative as of yet from the commission on that work group. If you're interested, please reach out to Teresa Lee if you're interested in serving. And lastly, many of you know that early in the Hogan administration, I did commit to improving, modifying our what are called the procedural regulations. Last summer, we completed our first draft, circulated those for public comment. Comments have come back. Staff led by our 2 assistant AGs are working through those comments, and we hope to have a draft ready to put forward as proposed regulations by the end of the year. There are some issues to consider. Typically, Department of State documents does not accept proposed regulations during the start of the legislative session. So although we may promulgate them, they may not actually be published until later on next spring. But I think we should go forward on the pace we've established for ourselves and get complete. This is a big, ambitious effort. Fortunately, we have had a lot of significant accomplishments, and the governor has not held us too accountable for not having these complete up to this point. But our aim is to have them released as proposed regulation by the end of his term, which would be, I think, a good achievement for staff. That concludes my remarks. Happy to answer questions.
Quick question, Mr. Executive Director, just in terms of the exogenous factor clause, in terms of getting CMS to give us a waiver of reduction, do you have any idea what kind of exogenous factors we might cite?
I think the one that I have not looked at the approach that either Vermont or state of Pennsylvania took, but I think the impact on of the COVID-19, particularly the impact of Omicron earlier this year, might be something that we could use at least to account for some of the deficit in achieving the savings. I don't want to get ahead of the HSCRC in this, but I think that's obvious. Keep in mind that about 45% of Maryland hospitals were in the crisis mode of care earlier this year. About almost half of patients at that point were Omicron COVID-19 patients, so it had a significant impact. The challenge will be, I think, to try to differentiate what was unique about Maryland, whereas many other parts of the country face similar challenges. The reality is that in that sense, I think the model incentives that were in place kind of worked against us in that revenue was stabilized, even though there were wild fluctuations in utilization, which might be a major factor in the failure to meet, or appears to be that we won't meet the savings targets for 2022. So more to come on that. I suspect that we wouldn't tag it all to the exogenous factors, but I think it certainly contributed in a major way.
Thank you very much. By the way, it's my first time, so I'm going to go back and just say, before we consider any further action items today, I'd like to remind commissioners, if you have a conflict, if you wish to recuse yourself on any action item, please inform the chair. If you had to recuse yourself for the last one and you didn't, shame on you. For any commissioners participating remotely who desire to recuse, remain silent, turn off your cameras, mute your phones. Those in room 100 who are recused should move to the small conference room. We have snacks. Moving on to agenda item number 4, exemption from certificate of need review. This agenda item is an exemption from certificate of need application filed by Communicare Health Services to change the bed capacity between 2 of its comprehensive care facilities, Forestville Healthcare Center and Clinton Healthcare Center in Prince George's County, Maryland. Jean Marie Gowell, CON analyst, and Winnie Hawk, our chief of CON, will now present the staff recommendation. Take it away.
Good afternoon, commissioners. Communicare Health Services is a privately held company and national provider of post-acute care. It operates 18 comprehensive care facilities in Maryland. In Maryland, nursing homes are licensed as CCFs. This project involves changing the bed capacity between 2 of Communicare's CCFs in Prince George's County. The first CCF is Clinton Healthcare, which currently has 267 beds, and the second is Forestville Healthcare Center, which currently has 162 beds. The project will result in the enlargement of Forestville via a new wing, which will add 37 beds, and correspondingly, there will be a reduction of bed capacity operated at Clinton. Since both of the CCFs are in Prince George's County, these moves maintain the existing bed supply without any increases. As a result of the change, neither facility will continue to operate with rooms that accommodate more than 2 patients per room. This proposed project is the first step in the applicant's main goal, which is a more comprehensive and strategic improvement plan to eliminate all patient rooms licensed for 3 or 4 beds throughout CommuniCare's 18 Maryland facilities. The long-term plan involves closing and downsizing several CCFs, renovating existing facilities, and constructing new CCFs. If the exemption is approved, the second phase will be at Fort Washington Healthcare Center, which is also in Prince George's County. The project plan is for Forestville to renovate 11,000 square feet of existing space and add 33,000 square feet of new construction. Clinton will need no structural renovations, only improvements to its flooring, paint, artwork, and furnishings. The total cost of this project is $31 million and will be funded through a combination of cash, mortgage, and working capital loans. Staff concludes that CommuniCare's application for an exemption from a certificate of need is in the public interest and is not inconsistent with the state health plan and will result in the delivery of a more efficient and effective healthcare services. Therefore, staff recommends that the commission approve the project with the following 2 conditions. 1, CommuniCare will temporarily delicense CCF beds at Clinton upon completion of this project to eliminate operation of any 3 or 4 bedded rooms. And 2, CommuniCare agrees to execute a memorandum of understanding with Medicaid to maintain the required proportion of Medicaid patient days for both the Clinton and Forestville facilities. Representatives from CommuniCare are in attendance at the commission meeting today. Charles Stoltz, partner, Karen Hall Thickman, Divisional Vice President of Operations, Tarnisha Fitzgerald, Divisional Director of Clinical Operations, Anita Dreyer, Divisional Director of Clinical Reimbursement, Holly Norelli, Vice President of Special Projects, and Howard Solins, Legal Counsel to CommuniCare. This concludes my presentation. We will be happy to answer any questions that you have.
Thank you very much, Jean Marie, and welcome to everyone from CommuniCare who's on the line. So first, Commissioners, do I have a motion to approve the certificate of need review for CommuniCare Health Services? Commissioner Jordan, do I have a second?
Second.
Commissioner Bazinski, thank you very much. Discussion.
That's straightforward.
Going once, twice. All right. Anyone on the line? Any commissioners? All righty. In that case,
So-
all,
This is Howard Stallings. I just wanted to express my deep appreciation to the staff who worked very hard with us on this first project. You'll be hearing from us on what is a step-by-step plan that will invest over $100 million in improving nursing homes throughout the state of Maryland at no increase of cost to Medicare and Medicaid. So we look forward to working with the commission and the staff and appreciate all their work.
thank you, Howard. We haven't approved it yet, though.
Oh,
But having perfect timing, all in favor?
Aye.
Any opposed?
Aye.
CON, thank you very much. Thank you, Howard. Thank you, the team. Thank you, Jean Marie Wynn. Hereby approved.
Thank you very much. We appreciate your support.
On to agenda item number 5. A certificate of need application filed by Encompass Health Rehabilitation Hospital Southern Maryland LLC for a 10-bed addition to its previously approved certificate of need for a 60-bed rehabilitation hospital in Bowie, Maryland, Prince George's County. Jean Marie Gall, CON analyst, back again. Will present the staff recommendation, please. Proceed.
Good afternoon again, commissioners. Encompass Health Rehabilitation Hospital of Southern Maryland LLC is a subsidiary of nationwide provider Encompass Health Corporation, which also operates another rehabilitation hospital located in Salisbury, Maryland. The proposed project is a 10-bed addition to the May 21st, 2020 Maryland Healthcare Commission approval of a 60-bed rehabilitation hospital in Bowie, Maryland. The beds that are the subject of this CON were historically located at Laurel Regional Hospital. In a March 2018 determination of coverage, the commission approved the relocation of the inpatient rehabilitation facility from Laurel Regional to the now closed University of Maryland Prince George's Hospital Center, who then requested temporary delicensure of 18 of the 28 total beds because it could not accommodate more than 10, and subsequently sold the other 18 beds to Encompass Health as a contribution to its 60-bed hospital. In April 2021, the remaining 10 beds were temporarily delicensed. The addition to the hospital will be 5,899 square feet of new construction, including 10 private patient rooms, a nursing unit, storage space, a day room, and general circulation. The estimated total project budget to complete the 10-bed addition is $13,109,242, which the applicant will fund with a cash loan from its parent company, Encompass Health. Regarding need, the service area will be the Southern Maryland Health Planning Region, which includes Calvert, Charles, Prince George's, and St. Mary's counties, as well as select counties in Anne Arundel County. As well as select zip codes in Anne Arundel County. In addition, the commission's most recent net bed need projections support the 10-bed addition. Regarding impact, there is no new impact for the commission to consider because the 10 beds it seeks to add to the facility were included in the inventory at the time that the 60-bed hospital was approved. The applicant does not anticipate any adverse impact to other inpatient rehabilitation providers with these 10 beds. Regarding viability, the applicant provided to us financial statements that show Encompass Health has access to the cash necessary to fund this project. The applicant also projects it will reach an occupancy rate of 94% by the 5th year of operation and will generate positive net income also by the 1st year of operation. The proposed project has 20 letters of support from state and local government, educators, executives, and clinicians. In conclusion, based on the review of the project's compliance with the Certificate of Need review criteria, staff concludes that the project complies with applicable school standards, is needed, is a cost-effective approach to meeting the project's objectives, is viable, and will have an impact that is positive. Staff recommends approval with the following 3 conditions. In its request for the first use approval, the applicant shall provide information acceptable to the commission staff that details the activities it has undertaken for outreach in the community regarding the availability of charitable services. 2, maintain compliance with the provisions regarding the availability of charity care and a sliding scale of discounted charges for low-income individuals who do not qualify for full charity care. And 3, prior to first use, provide written transfer and referral agreements acceptable to commission staff. Representatives from Encompass Southern Maryland are joining us today. Abraham Sims, Senior Vice President, Carrie McRae and Susan Lyrie, Associate General Counsel, State Regulatory and Compliance, Sheila Terry, Regional Vice President and Controller, Ella Aiken and Allison Best Luch, Counsel to Encompass. In addition, Marty Chafin, President of Chafin Consulting Group, and Cynthia Keller, CEO of the University of Maryland Rehabilitation and Orthopedic Institute. This concludes my part of the presentation. We'd be happy to answer any of your questions.
Thank you, Jean Marie. I do have a question. How's Encompass doing right now with charity care?
So right now, the 60-bed hospital is not open yet. So for the purposes of this CON, we looked as a proxy at the Salisbury Hospital, the one that's already open in Salisbury. And let me find the page that's on. They have made improvements to the charity care. So in 2018, so now what this is about Salisbury, the charity care was at 0.007%. And then they achieved 0.66% in 2019 and 1.549% in 2020. So they were trying to get towards 2%. So they were making that improvement, and then COVID came, and then they took a slight dip after that year. So in 2021, the charity care dipped to 0.49%. Like I said, because of the COVID. And this year, year to date, they're at 0.77% in the first 6 months. So they are doing better again. So they made some improvements, took a slight dip,
Right.
and are doing a bit better now.
By the way, welcome to Encompass. And in that case, do I have a motion to approve the certificate of need for Encompass Health Rehabilitation Hospital Southern Maryland LLC? Addition of special rehabilitation beds in approved but uncompleted special rehabilitation hospital. Commissioner Dordan, is there a second? Commissioner Bazinski, thank you so much. You're too slow. You're quicker on that buzzer. Any discussion? Anyone on the line? Commissioners on the line, any discussion? Any questions? All righty.
So what is
In that
the
case-
goal for charity?
Please, Dr.
What is the goal for, this is Commissioner Bhandari, what is the goal for charity? What percentage? I see the numbers were, quite dismal, and after that COVID hit, what they are planning to do in the future, what number they want to do.
So the way that we look at it is that we look at all the hospitals in different quartiles, and what the standard looks at is that the applicant not be in the bottom quartile, which I believe was the last report we have is from 2019. So that was, I believe, 1.1%. The median is 1.8%. What Salisbury committed to was 2%. So those are sort of like the numbers in terms of what we want them to achieve.
Is there a certain number of years they have to achieve, or 1 year, 5 years, 10 years duration?
Just to make progress towards that goal. For Encompass Salisbury in particular, their goal was 2.0%, and they were supposed to make progress towards that goal before first use approval of the hospital.
Thank you.
Commissioner Boyle.
Following up on that same question, first use, we want to see the progress. How do we ascertain over time that they are meeting their goals?
That is a great question. I'm not sure exactly the answer to it, but I could get back to you as to how we keep track of that or manage it. I know that we get our quarterly reports up until there's a first use, but then your question is after first use. Yeah, I can find out for you and get back to everyone.
This seems to be a condition for so many CONs, and I'm just curious for the long term how that works out.
Yes.
You and I are taking a field trip.
Typically, on occasion of the next application, we look at that again. And if they have not met their commitments from a previous CON, that would be brought to the attention of the commission. And we would have the potential to add a more stringent provision regarding charity care.
So as they come back again.
Yes, it's not the strongest type of bar, but it is, we are exercising our authority under the statute to the extent we can.
Great. All right, if that concludes our discussion, all in favor? And
Aye.
any, thank you, and any opposed? Sold. All right. Thank you very much. The motion is approved. You have your CON. Jean Marie, thank you so much. Encompass, thank you so much for being here.
Thank you, Chair. And again, if I may, Encompass does have several representatives present and would like to just briefly make a statement to the commissioners.
Absolutely.
Thank you, Commissioner. This is Abe Sims. I'm the regional president for Encompass Health, and a lot of work goes into this on behalf of your staff. I really appreciate all their hard work, and for you as commissioners, I appreciate the careful consideration, your questions, and we're honored. We're really excited to serve the patients in Prince George's County in partnership with the University of Maryland, and we really appreciate your trust in us.
Thank you very much. Appreciate it. All righty. Moving on to agenda item number 6. Data Release Advisory Committee nomination is required by COMAR 102505. The Healthcare Commission staff is developing a data release advisory committee made up of a diverse group of industry stakeholders and other related interested parties, including but not limited to academic research organizations, consumer advocacy groups, payers, providers, employers, and other state agencies. Maled Khanjit Solomon will present the nominations. Mahi? She here? Oh, she's online. There you go. Mahi, please proceed. Thank you.
Thank you, Commissioner. Good afternoon, everyone. Before presenting the list of nominees, I would like to provide a background on the COMAR 1025-05 Data Release Authority. Next slide, please. COMAR 1025-05 was approved and adopted at the end of 2021. The impetus for the regulation was the need for improvement of the regulation governing MCDB data release and all other data to which MHCC is custodian to. So this includes the expanded use of the APCD, which is the MCDB data, through an expanded data release process, offer diverse data sets. These are like standard, limited, and custom data sets with linkage capabilities. It also expands the list of eligible applicants. This is organizations such as non-government, government, researchers, and for-profit entities. As part of the improvement, a comprehensive application and pre-application package was developed, and also which includes a data management plan and a template data use agreement. The chapter also better aligns the review standards for Medicaid data to the commercially insured component of the MCDB. Regulation 7 of COMAR 1025-05 also helps create a transparent, thorough, and efficient review process. Last but not least, the COMAR also requires to establish a data release advisory committee. I want to also note that under this improvement process, COMAR 1025-06 that governs the data intake of the MCDB was also updated, and also the COMAR 1025-11 was also replaced by 1025-05. Next slide, please. The regulation has 11 sections, among which 8 and 9 pertains to the Data Release Advisory Committee and the responsibilities in relation to the review of an application. Next slide, please. To look at the Data Release Advisory Committee requirement, we'll take a deep dive into Regulation 8 and 9. While the establishment of a DRAC, the DRAC composition in terms of the member composition and the total number is within the discretion of the Commission. The DRAC performs the review function of a privacy board as described on 45 CFR 164. As mentioned earlier, the member composition would include academic research organization, consumer advocacy group, employer, healthcare providers, HMO, insurer, and nonprofit health service plan. The DRAC's main responsibility is to review an application, whether it meets the approval criteria, which could include whether the applicant demonstrated the data requested is the minimum amount necessary to achieve the intended purpose, and also how the applicant has provided an adequate data management plan showing how the data will be stored and used securely. The other is whether the applicant's project objective is within the public interest. Next slide, please. As mentioned earlier, the member composition would have various stakeholder groups and at least one member from Medicaid and at least one commission staff member who will serve as an ex officio for administrative purposes in any additional representative that the commission determines are needed. I also want to note that the ED may remove a member of the DRAC for neglect of duty or misconduct by providing a written notification. And this is also within the COMAR. Next slide, please. So moving on to the DRAC member responsibilities. The drug will serve for a term not exceeding 3 years. And at the end of the term, the member will serve until a successor is appointed, and a drug member could also be reappointed. The drug shall meet as needed in terms of to review the completed application, prepare a report and recommendation with the administrative support of the commission staff, and submit that to the ED. If requested by commission staff or the ED, the DRAC will provide advice, consultation, and expertise on issues that may arise while reviewing the application. The DRAC also would perform other duties and obligations that are required under this chapter. Next slide, please. Next slide. So moving on to the DRAC nominees under the various stakeholder categories. The first one we have is Academic Research Group, under which we have the nominees from Johns Hopkins School of Public Health and the University of Pennsylvania Health System. From JHU, we have Elise Lassar. Dr. Lassar is the current assistant scientist and center coordinator for the Center for Population Health IT. She manages large-scale health IT research projects, develops research proposals, maintains relationship with collaborators. Thank you. And coordinates the activities of analysts, faculty, and students involved with the CPHIT. From University of Pennsylvania, we have Srinivas Sridhara, who is a PhD holder and is the Chief Data Analytic Officer at Penn Medicine, working on enabling and driving Penn Medicine with transformative care research and education. Srinivas was previously the Senior VP and General Manager of Clinical Transformation and Risk at Optum Lab and at the Research and Development arm of the United Health Group. Within the consumer advocacy category, we have Elizabeth Senis. During her professional career, Senis had a senior executive position with various health insurer organizations such as the Mid-Atlantic Medical Service, United Healthcare, CareFirst, Blue Cross Blue Shield, and Evergreen Health. From the employer group, we have Aaron Davis. Mr. Davis is currently the founder and CEO of SwitchBridge, where in addition to managing the company, he leads products, concept, and design and innovation. Next slide, please. Moving on to state agency category, we have Alyssa Brown from Medicaid. Ms. Brown is the Director of Innovation, Research and Development for Medicaid, and she's responsible for leading healthcare delivery and payment reform and overseeing program evaluation, data analytics, and managing the Health Choice Demonstration Waiver Program. From our sister agency, HSCRC, we have Claudine Williams, who is the Deputy Director for the Medical Economics and Data Analytics Center at HSCRC. In this role, Claudine directs a team of staff responsible for collection, aggregation, and dissemination of hospital discharge data. Within the category of state agency, we are waiting for representative from the state's strategic data initiative, which we expect to have within the next couple of weeks. Next slide, please. So moving on to the privacy, security, compliance category, we have Bezawit Sumner from CRISP. Ms. Sumner is the Director of Security and Compliance at CRISP and is an experienced information security professional with a demonstrated history of working in health IT. Next, we have Katrina Pagnilin, is the former Chief Compliance Officer, Chief Privacy Officer for the Maryland Health Benefit Exchange with 30 years of experience in the management of organization, the role of privacy and compliance policy. In the professional association category, we have Edward Hunter. Mr. Hunter is a public health and public policy consultant. He's a senior advisor to the National Alliance to Impact the Social Determinants of Health and project director of the Robert Wood Johnson Foundation Raising the Bar initiative. Lastly, we have our provider category and a representative from Maryland Health Association, Ahmed El Said Ahmed. Mr. El Said Ahmed is the Director of Strategic Alliance at MHA, where he conceptualizes data analysis to identify trends, opportunities, and performance improvement to reduce the total cost of healthcare in Maryland. Next slide, please. Staff recommends that Commission approve the nomination to the Data Release Advisory Committee. And next slide, please. That concludes my presentation. I would like to kind of provide the next step once the decision is made. Thank you.
Great. Thank you so much, Mahi. Great presentation. Great slate of people. Do I have a motion to approve the Data Release Advisory Committee nomination? Quick on the draw. Thank you, Commissioner Boyle. Second, Commissioner Brzezinski. Thank you very much. Shall I have a discussion on the nominees?
I have a question. Perhaps this is more for Ben. In one of our prior meetings here, we discussed a data release for some research in the city of Baltimore. And, we approved it, I believe, that was on our agenda. So this committee then would take the place of those data release requests coming to us, and they would be able to administrate the data release. I assume this is from CRISP, or is there other data resources?
So this would not be typically a CRISP data release. This would be a release of the data systems that MHCC directly controls, which would be this all-payer claim database. We also, through an agreement with the DC Hospital Association, do for a narrower range of use cases, have the ability to release DC hospital data, but the use cases have to specifically apply to health planning and CON applications, where an applicant or interested party needs to know about utilization by Maryland residents that are going into DC. So those two data systems would be the principal ones. It is possible that there would be other data systems that HCC has direct control over, but CRISP would have its own data release authority. We would expect them to administer independent of our own on data systems. For example, their clinical data research. They have a process too. Now, previously, these requests came directly to the commission. The new process, as a result of the regulations in 102505, we changed that so that we, consistent with HIPAA, established what we call the Data Release Advisory Committee, the DRAC, which operates as a data privacy board, consistent with HIPAA. They would review the applications. The applications would not come to the commission directly. They would come to the executive director. The executive director could act on those applications if they were judged routine, consistent with what had been released before, or the executive director could punt it to a subset of commissioners that would also take a look at it, or alternatively, ultimately to the full commission. But we can try to align what we thought were best practices on data release done by other states. And an independent data review is really a best practice. I want to try to do that.
Very well, thanks for your perspective. I appreciate it.
Thank you, Commissioner Brzezinski. Thank you. All right, that concludes the discussion. Then we'll vote. All in favor? Oh,
Excuse me, can I just one follow-up question to Ben's
Absolutely,
description?
Commissioner O'Grady, please.
So Ben, the final decision-making, unless you decide to punt it forward, is going to be with you from this point on. And I'm not opposing that, I'm just asking for a clarification.
That's correct. I think that, you know, an executive director would want to carefully consider what the precedents have been, but yet a final decision, a final endpoint is the executive director. The executive director could say, you know, this is not routine. The DRAC is active, but we can punt that forward. Is that correct, Mahi?
Yes.
And the executive director cannot independently authorize this unless it comes through the DRAC, and you're just ratifying the decision of the DRAC. You can't independently release data.
That's correct. The executive director or staff.
Well, you can reject it.
Cannot independently, absent a DRAC action, just automatically approve it.
Right. I guess my concern in terms of just good governance is I don't mind the idea of the commissioners themselves being taken out of the loop on this, and I think you're quite capable to do it. But I do worry about a draft that is totally independent and doesn't have the oversight of having to send whatever they recommend on to you for the actual, you know, I mean, you're the actual state employee, kind of officer of the state. This is a very qualified group you've got here. I just know in terms of accountability, I'm more comfortable if you're the final arbiter with us as your backup if you would like to kick it upstairs rather than a totally independent draft.
I agree, Commissioner O'Grady.
Okay. Are we in favor of the motion as is? All in favor?
Aye.
Any opposed? The ayes have it. The Data Release Advisory Committee nomination is hereby approved. All right, moving on to agenda item number 7. The Maryland Healthcare Commission is required by Senate Bill 734 to convene a work group to annually study primary care investments and make recommendations based on its findings that include quality and access to primary care services, among other things. The law requires broad stakeholder participation on the work group. David Sharp, Director in the Center of Health Information Technology and Innovative Care Delivery, will represent 2 nominees for commission consideration. David, please proceed.
Good afternoon, commissioners. Good afternoon, Mr. Chairman. So I wanted to present to you this afternoon the nominations of Tyler Blanchard and Ronald Gresh to the Primary Care Work Group. Next slide, please. As noted by the chair, Chapter 667 of the 2022 Laws of Maryland requires MHCC to convene a primary care work group and submit an annual report to the Governor and General Assembly. In 2023, the work group will develop the annual reporting plan. Starting in 2024, they'll be reporting to the legislature. Next slide, please. Listed on this slide are activities of the work group. They include an analysis of primary care spending, developing plans to improve quality and access to primary care, identifying strategies to reduce access barriers to primary care, and identifying approaches to increase the primary care workforce. Next slide, please. Mr. Blanchard is Aledade's ACO Market President for Delaware, Maryland, and the District of Columbia, and is the ACO Board Chair for more than 100 primary care practices who participate in payer-specific accountable care organizations, LLC. Mr. Blanchard serves as an advisor to the Delaware State Primary Care Reform Collaborative. Prior to joining Aledade, he was the executive consultant for Cumberland Consulting Group, a leading healthcare consulting firm that helps payers and providers implement and optimize health information technology. In addition, Mr. Blanchard was a project management office analyst at Bearing Point, a national management and technology consulting organization. Next slide, please. Mr. Gresh is a leader in actuarial modeling, rate negotiating, and policy development, and served with the federal government for 42 years. Mr. Gresh works part-time as a consultant for the U.S. Office of Personnel Management, where he focuses on Medicare, long-term care insurance, and the Postal Service Reform Act of 2022. Prior to his retirement, he served as a senior health actuary at OPM and was the primary negotiator of health insurance premiums for the Federal Employees Health Benefits Program. In 2014, the American Academy of Actuaries honored Mr. Gresh with the Robert J. Myers Public Service Award in recognition of his contribution to public service. Next slide, please. Commissioners, staff recommends that the commission approve the nomination of Tyler Blanchard and Ronald Gresh to the primary care work group.
Great, thank you very much, David. Do I have a motion to approve the primary care work group nominations? Commissioner Buzinski.
Aye.
Hello, my friend. Second, Commissioner Boyle. Okay, great. Is there any discussion on the nominations?
I have a question. There really isn't a category here that I can tell, perhaps under other that would be more from the consumer patient side. Is there?
So that's a great question, Commissioner. So what I would say is, under how we've structured it to this point, is that under other representative, where we looked at employers by way of example, we tried to find employers that would bring both the perspective of the purchaser's side of the equation, but also represent the consumer. So the actual category of consumer is kind of blended together, but I think you bring to light a point for future consideration regarding perhaps a designated slot for consumers for consideration. I would also note that many of the providers here have served in consumer capacity roles in other work groups that they participated on, both within the commission but in other organizations.
Yeah, I think adding that category would be important.
Good point. Thank you.
One point of clarification on that. Also, if you think about what, if we do decide to go ahead and kind of agree with this recommendation for Ron Gresh, his main last 20 years has been negotiating kind of the best competitive premiums for the most benefits possible in the entire FEHB program. He's a little modest in this. When I was working on the Hill, he was basically the chief actuary for FEHB. So that is certainly a perspective that is, you know, consumer in an intermediate role of, you know, what are they getting for their money? How are we keeping premiums as low as they can be, but making sure that everybody's getting the benefits that has been agreed to. So not a direct the same as having like someone from the American Cancer Society or whatever, but it's still, it's certainly not a corporate perspective, if you know what I mean.
Thank you, Commissioner O'Grady.
This is just an information question. All these folks spend a lot of time and energy to do that. Is there a reimbursement component to being on these committees? Things? Are they? I assume expenses, but is there are you paid to be on these?
So our executive director may want to weigh in here for more information, but our work group staff that are staffed by external stakeholders are not paid to participate as a paid member of the group. There are some work groups that are established in state government where their expenses, such as travel, are paid, but this is not one of them.
Is that right?
And I defer to Ben for additional.
That's fine. I was just curious as
Unless it's spelled out in the legislation that the work groups shall be reimbursed for travel. We tend not to provide that benefit.
We used to get M&Ms.
And typically the work group members do not get per diems. It's on some cases there is allowance for travel. Obviously, some people have elected not to do it because of that limitation.
Thank you.
All in favor of the motion to approve the nominations?
Aye.
Aye.
Opposed? Guys have it, the nominations hereby approved. David, thank you very much. Thank you, Commissioner. Agenda item number 8, presentation overview of the draft changes to Comar 102410. Eileen Fleck, Chief for Acute Care Policy and Planning, will provide an overview of changes to the State Health Plan chapter for acute hospital services, Comar 102410. The changes presented are based on feedback from work group discussions held over 4 meetings between August 2021 and June 2022, as well as internal staff review. Eileen?
Thank you. Good afternoon, Mr. Chair and Commissioners. The regulations in Comar 102410 are the ones most frequently used in Certificate of Need reviews and were only last updated in 2009. In 2018, a task force was formed that focused on modernizing the CON program, as many of you might be aware. This task force recommendations included minimizing regulatory requirements for existing providers to expand, reducing the burden of CON regulatory requirements, and complementing the goals and objectives of the Health Services Cost Review Commission. Staff used that information and the feedback from the work group in updating the State Health Plan chapter for acute hospital services. Next slide, please. So this slide shows the goals, as I just talked about, based on that information in terms of the prior study and the work group feedback. We wanted to remove obsolete references and standards, reduce burden on applicants, update the regulations to reflect new priorities of MHCC, and we wanted to align with HSCRC's goals. Next slide. In the current State Health Plan chapter and most other chapters, there's a set of policies that articulates the values and goals that inform the standards that are then included, which are used to evaluate specific CON projects. There are 6 policies in the current chapter, and each of these was revised based on input from the work group. For conciseness, I have sometimes abbreviated the policies rather than quoting them exactly. The first policy on this slide emphasizes providing cost-effective care while meeting patients' needs, which is consistent with HSCRC's goals. The second policy shown focuses on promoting access and care and acknowledges that barriers to access and care can stem not only from travel distance or limited finances, but also race, ethnicity, and gender. The current policy focuses only on geographic and financial barriers to access. Next slide. The first policy statement on this slide is essentially the same as an existing one. Hospitals and health systems will consider smart and sustainable growth policies as well as green design principles. The second policy statement is also very similar to an existing policy, but it emphasizes that the goal is to provide high quality, cost-effective, patient-centered care rather than to contribute to practices that would be expected to lead to that result. So it's just a slight change. Next slide. This policy is very similar to an existing one. The recommendation from the work group was to modify the policies to state that specialized services should be provided on a regional basis when it serves to promote quality and cost effectiveness while maintaining sufficient patient access to services. The second policy statement on this slide replaces the current policy statement, which is outdated because it refers to an all-payer rate setting system rather than referencing the global budget approach, which is now what HSCRC is using. It also specifies that coordination with HSCRC on capital project reviews is important because that will help streamline the CON review process. Next slide. For this next section, I'll be going over the general review standards. There are 3 general review standards that pertain to information regarding charges, charity care and financial assistance policy, and quality of care. These are standards that apply widely across hospital projects, and these standards are often referenced in other state health plan chapters for specific services. In the current chapter, the standard for information regarding charges has a requirement concerning the posting of charge information, which no longer seems necessary because of new CMS requirements for posting charge information. In addition, because HSCRC updated its regulations, the staff agreed that referencing CMS and HSCRC requirements related to price transparency is appropriate. Under the current regulations, CON staff normally review a hospital policy but it does not seek out other evidence of compliance with those policies beyond checking for charge information posted. The work group suggested that rather than relying on just a review of the policies, that we have more meaningful verification of compliance, which we plan to do by gathering information from the hospital directly from HSCRC and also the Health Education and Advocacy Unit of the State Attorney General's Office. Next slide. With respect to the charity care and financial assistance policy, it's similar to what we already have in terms of there needs to be a written policy for the provision of free and reduced care, determination of probable eligibility within 2 business days. Also, hospitals in the bottom quartile for charity care needs to demonstrate the appropriateness of the charity care provided. And then similar to the other standard I just mentioned, there should be some verification of compliance through requesting information through sources like the
Good. How are you?
Excuse me, can you please mute your phone? Thank you very much.
So verification through requesting information from HSCRC and the Health Education and Advocacy Unit of the Attorney General's Office. Next slide. In terms of quality of care, it currently is a requirement that the hospital be licensed and in good standing, that it be accredited by the Joint Commission or other accreditation organization, which is also considered acceptable. One of the key changes we made is that instead of having a standard where the hospital needs to address all the performance measures that are in our consumer guide, which is quite a few, we've tried to reduce that number and focus on the key things that should be looked at for all project, things like patient satisfaction, patient safety, infections, and then only pick out the ones that seem relevant to the project in terms of other ones that a hospital should address. And then we've also specifically added that we should look at those quality metrics tracked by HSCRC. Those change over time, and usually it's just a few of them, which is tied to the agreement with CMS. Next slide. In terms of the project review standards, I touched on this with the policies. There's a requirement for adequate geographic access, and then also we have a standard that addresses the potential for non-geographic barriers to access, which can include things related to patient's race, gender, or ethnicity. Next slide. For the identification of bed need and addition of beds, we have in the current plan a bed need projection where it results in a range in terms of a low end and a high end, and that is used to determine if there is a need at all for beds. And we've decided to de-emphasize that and focus more on an applicant doing a service level analysis. I'll talk more about the bed need projection, how we've changed it near the end of my presentation. Next slide. In terms of the adverse impact standard, a hospital capital project should not have an unwarranted adverse impact on charges, availability, or access to services. This is essentially the same as the current standard. We've only tweaked this one a little bit. If a project, and then also if a project reduces the potential availability or access to a facility of service, an applicant must demonstrate that changes will not inappropriately diminish access to care. Next slide. For cost effectiveness, this is one where some members of the work group question the utility of it, but staff feels that it does serve a useful function without being excessively burdensome. So this is something where currently applicants do need to identify 2 alternative approaches to achieve the primary objective of the project. And so we've recommended maintaining that. There's no significant change to this standard. Next slide. For the financial feasibility standard, an applicant needs to document that utilization projections are consistent with historic use or the state health plan projections if relevant. revenue estimates need to be consistent with utilization projections. And we've added language to state that the hospital proposing to increase its global budget needs to account for the capital project and must file a timely rate application with HSCRC. So this is more of just making sure that we're coordinating with them and keeping the process more timely in terms of coordination. Next slide. So most of the other project review standards, there are not really major changes, only minor changes or no changes at all. So I've just listed some of those other standards for project reviews that exist: the construction of hospital space, construction of non-hospital space, inpatient nursing unit space, efficiency, safety, emergency department treatment capacity and space, and emergency department expansion. There was only one standard that we removed, which was obsolete because of changes with HSCRC and its approach to budgeting. Next slide. So in terms of the methodology for bed need, we've recommended not having projections for pediatric beds. It's very rare that someone comes in and asks to add pediatric beds, so it doesn't seem necessary. It seems like an applicant can just do the service area level analysis and that should be sufficient. We're recommending that instead of the DRGs, that we rely on the major diagnostic category. We've already kind of moved towards this in some of the other chapters. It just makes it a little easier because the DRGs are frequently updated. I don't think it will really change anything in terms of the results of the bed need projections. We've also added language that allows for deviation from the methodology in exceptional circumstances. So because of the pandemic, there was this big dip in the first quarter, maybe second quarter of 2020. And I think it's also changed things a bit in 2021. So we think it would be rare that we would want to deviate from using the historical numbers, but because something like that could happen, it makes sense to build in some flexibility. In that situation, what we would do is that we would explain what we're doing in terms of deviating from the standard methodology, wanting to maybe leave out a year or leave out, or maybe some other change. And we would put the projections out there for public comment. And so people could comment if they had concerns about how we were changing the methodology before we then published final projections. So again, we are de-emphasizing the bed need projections. I would say currently, if the range did not show there was a need, then that would really shut down an applicant's ability to justify additional beds. And the way that we've done it is that it really is more about the service level analysis. An applicant still needs to address the bed need projections, but that does not have as much control over whether a project would be approved. Next slide.
I have a question there on that previous slide. It's Commissioner Brzezinski. It's a question about the pediatric beds. I assume if someone's opening a pediatric hospital or a wing, then they would use pediatric beds. They'd look at that need. Just kind of clarify for me where children do end up in hospitals still, and how do we account for that?
I'm sorry, could you repeat that question?
Sure, yeah. Your first point is no projections for pediatric beds. How does it apply to a hospital that's expanding a pediatric unit or pediatric hospital? How do we account for beds availability for pediatric patients? And my understanding is we're quite over capacity right now in much of Maryland, and it's a surge issue, but where do peds beds come in your analysis for state health plan, et cetera?
Well, it would really be evaluated based on an applicant saying that they wanted to build additional pediatric beds or expand. So instead of having, I guess, prospectively saying, here's what we think is the need for pediatric beds, we don't think that would be useful, because overall, I think not just pediatrics, but actually with adults, there's a bit of this downward trend where we're not increasing the utilization of the inpatient beds. It's actually kind of been going down a bit over time slowly. And so that would affect the results of the projections. And we think because it's so rarely used that it's not necessary to have the projections, but it doesn't inhibit anyone. It would just be something where we rely on what the applicant says in terms of justifying it.
Just a quick question. Yeah, just a quick question. What if a hospital came in and said, we're going to close our pediatric beds? That just a given that can happen? I mean, how do we deal? I don't know how we deal with.
I guess our fundamental question is how do we manage the number of pediatric beds in the state? How do we determine how many are needed? And how do we ensure there's adequate supply for routine care and also when there's surges and, you know, typically infectious processes that lead to children being hospitalized?
So just for the first question, what we're saying with regard to pediatric beds is the applicant would, we don't have a pediatric bed forecast that some applicant could then put forward an application and say, you say there's a need for 20 beds. This project would meet that need. Paul, correct me if I'm wrong, but instead, an applicant could come forward and make a case. They would be left to their own measures to make a case that pediatric beds were needed. By not setting a bed need forecast doesn't mean we're saying there's no way to do it. The applicant themselves are left to demonstrate that there is a need and they can meet it.
Slight correction. We actually give very specific guidance for a project like that. So if someone wanted to introduce pediatric as a new inpatient service that they hadn't provided in the past, or if they want to expand the number of pediatric beds that they operate, this new plan, which is a draft plan at this point, we're getting ready to post it soon for informal review and comment. It would say that that applicant has to do a service area level analysis. Eileen referred to this earlier, and it's pretty specific. They have to define their service area at a zip code area level, and that's obviously based on patient origin. If there is some historic patient origin, if it's a new service, we know what pediatric service areas look like because we look at other hospitals and we see what is the drawing area for this typical service. So they would have to do a realistic definition of their service area. They would have to look at use rate. So this is the population's use of pediatric services within that service area. What has been the historic pattern? And that would inform us on what we could expect in the future as far as demand in that service area. And then what is the market share? How much of the pediatric demand in that service area would it be realistic for them to capture? Again, we can look at that through looking at other hospitals. What is a realistic range of market share that you would typically expect a hospital to achieve for this service? So that's what they would be doing. That's the information that commissioners would be relying on in making a decision on the project rather than a bed need projection. And let me just say one more thing. The reason why we don't think the bed need projection really makes sense anymore is because there's actually been a pretty dramatic change in pediatric hospitalization. Eileen said it was gradual over time, but when we look at trends for the inpatient services we have, pediatrics has really declined significantly. They have 3 hospitals, general hospitals in Maryland now, that account for over 75% of all pediatric admissions. So in the other hospitals, the other 40 general hospitals that we have in the state, typically census is less than 1 patient per day. A few, it's 2 patients, 3 patients. We have a few kind of medium-sized community hospitals that might actually have a census 3 to 5. So there's just not the same level of use of hospital beds.
Paul, do you know the reason for that trend?
We just don't do some of the things that we used to hospitalize children for. We care for them in emergency departments. We sometimes observe them, but in general, we have a hospital system that disincentivizes admissions. So you deal with problems without hospitalizing patients. So we tend to, to me, when I look at the pattern of change over time, pediatric patients that get admitted to hospitals typically are surgical patients. just very few hospitals that have pediatric surgery as a specialty that they can really offer through their medical staff. And it's those 3 hospitals that I mentioned. So if it's a serious problem that requires surgical intervention, that's just not done at community hospitals anymore. They tend to go to Hopkins, University of Maryland, the bigger programs that actually have that particular type of specialty. But for the non-surgical, you know, we over time, historically, we've been able to just reduce the requirements for hospitalizing children for those purposes. We see a pattern in the wintertime where you're going to get more demand for kind of respiratory issues. And so we've tried to manage this service over time in hospitals by letting them come up with kind of innovative approaches. One of the themes that we've seen in recent years is emergency departments of hospitals will develop a kind of specialized area for pediatrics in the emergency department. And some of those even incorporate both outpatient ED treatment of the pediatric patient, but also they have observation spaces within that same unit. And if they need to keep them overnight, both, you know, for observation or actual admission for a short stay, that's all incorporated in one unit. That's when you have very small census, that's a much more efficient way to deal with it than having that pediatric unit up on the 3rd floor, because those are empty. You can't efficiently staff those, and there just isn't the demand to justify that. So when we look at pediatrics, it doesn't make sense for us to say, oh, we need X number of beds here because the service has changed so much.
Observationally in my career, it seems that with advances in vaccinations, that has vastly reduced inpatient need for pediatric services. You know, much of what hospitalized children 20 years ago is now vaccine preventable. So it's, you know, especially as flu vaccines become available as well. I mean, most of the things that put kids in hospitals we can vaccinate against them.
As long as you don't have the anti-vaxxers taking over.
And to the question on closure, there is a notice provision if it's in if a pediatric unit closes, there's a notice provision if it's in a jurisdiction with more than 3 hospitals. And if it's less than 3, there would have to be public information hearing before they could close that unit. The most recent example that I'm aware of is this closure of the Franklin Square pediatric unit, which they kind of sort of complied with that notice requirement about 5 years ago.
Historically, we've moved away from saying that CON is an appropriate tool for looking at closures of facilities or eliminating particular inpatient service. Because, you know, we're not really a program that's equipped to address usually the, you know, decline in census that's occurred that's led to those decisions. We're not really equipped to say, oh, we absolutely have to have this service. And certainly when we look at pediatrics, that doesn't seem to be something that makes a lot of sense. And then financially support that. We're not that kind of agency. So, but as Ben notes, that is something that you have to notify us about. And sometimes we require you to have a public hearing before that closure goes through. Specify what sort of things we want you to address in your plan for closure or elimination of the service.
Excuse me? Eileen, are you done with your presentation? Are you available to take questions on other parts of it? We sort of seem to stop before the last slide.
It's fine to take questions now. The last slide was just going to mention the process going forward, that we're still doing some internal review and we haven't posted it for informal comment, but that would be the next step. And then once we get the comments back, we would make further revisions before we'd be presenting proposed permanent regulations to you for voting.
Very good. I had a general question, and I think there's things on slide 11 and 12 that touch on it. In some of the other areas where we've done our COMARs, as we put this, and I know this is just the advisory group coming forward to us, there's been various criteria that give us certain, not direct, but an indirect advantage to the current providers in the state and disadvantage new entrants to the market. And I just wanted to know, just a little clarification of what they meant. Like you have on slide 11, it talks, your second bullet, a project reduces the potential availability or access to a facility. The applicant must demonstrate that changes will not inappropriately diminish access to care. And I guess one interpretation of that is overall, and I totally agree with that. But if we had new people come in who were more provided better care, had better quality, they would take market share away from the current providers. And I didn't know which interpretation of this I should take, that it's the overall system should not decrease, or any of the particular current providers might lose market share.
I would say the focus is not at all on providers. The word providers is not in the current
Okay.
regulations. It's not in what we've suggested. The focus is on the access to care. So I feel like it is appropriate in terms of what I've heard the commission articulate, where there is a de-emphasis in terms of protecting providers, but the importance is in terms of the patient access to care.
Very good. And then on the next one, you say no significant change to the standard compared to the current cost effectiveness standard. Now, we tend to have a somewhat, cost effectiveness out in the general sort of health policy community means something a little different than we often mean in this context. So again, is that cost effectiveness here? Are we talking level playing field between kind of current players and potentially new players? Or is it, again, a gentle nudge towards those people who are already in the system?
I would say the focus is really on the applicant and whether or not the approach they're taking seems like the best one based on the objective. So it really is not involving anyone else and an impact on someone else. It's
Right.
just alternatives that they considered. And it's something where we feel like sometimes we get really good information and good alternatives, and sometimes it maybe feels like they're just going through the motions, or people feel like, they really only see it one way and they're kind of writing something up just to fulfill the requirement. And we couldn't really come up with, I guess, a better way to phrase the standard or to change it so that we would make sure we only got good information that was useful.
Yeah, excellent. No, that's the right way to, I mean, that's the approach I agree with, certainly. The idea that there certainly are, and certainly you see it a lot in pharmaceuticals, where there's lots of great ideas, but they're all very expensive. They're not particularly efficient ways of providing, it's things like that. The idea is not to be cost effective. The idea is to generate profit. So it's kind of, can be the opposite. There's some who can figure out how to do both simultaneously, and that seems more the kind of applicant we're interested in. Okay, thank you very much for the clarification.
You're welcome.
Great. And more discussion on this. Who knew this would be the most exciting part? All right, well, thank you very much, Eileen. Move on to agenda item number 9, overview of upcoming activities. Mr. Executive Director, would you like to share the upcoming activities for the
Sure.
November public meeting?
There's a couple things I'm going to call up staff to ask to provide some just brief information on. We are moving into the fall months. Secretary Schrader, even as he's quote unquote running through the tape in his tenure, he's directed the state to prepare for another surge. I know that he has a surge team that both Paul and I are somewhat involved with, Paul more directly. There may be a role for the commission should there be a need for additional beds moving forward. Do you want to just provide a brief update of where that stands? Right now in the state, we have about 425 adult COVID patients hospitalized. That's manageable with the current bed capacity. Obviously, as I mentioned at the outset, earlier this year, January, we were up over 3,000 hospitalized patients. And the secretary is convinced we don't want to be in that scenario again. The momentum on this group has ebbed and flowed, but Paul's been a very persistent participant. Where does that stand right now in anticipation there might be emergency CONs down the road?
Yeah, so let me first say there are still over 20 emergency CONs that are in place. So they are valid through at this point, the end of April 2023. And those are the emergency, that's a subgroup of the total emergency CONs that we issued beginning in the spring of 2020. They represent the ones that really were activated. We approved some emergency CONs that were never really necessary. The hospitals, had that contingency plan approved to implement if necessary, but there were quite a few that were never implemented. So we did extend for a second time about 20 of those. And those are in place now. And we also have one of those emergency CONs, which was an alternative care site hospital. So the former Washington Adventist Hospital in Tacoma Park, along with Laurel, where I could say we were fortunate to have these two recently replaced hospitals or abandoned hospitals still up and running. And we were able to then use those. And they played a big role in 2020 and 2021 in terms of letting us handle the spike in census during these COVID surges. The one in Tacoma Park is still operating. Secretary Schrader convened a task force to look at how we're handling surges, how we handled them during the pandemic, and what should be the plan going forward. Basically, the plan is to try to handle surges that may be coming in the future without having to go with an alternative care site hospital model. It does tend to be kind of expensive. So the plan that is a work in progress right now is to have hospitals, strategically, a few hospitals throughout the state that actually are designated as surge capacity hospitals. They have the space, they have kind of census that would allow them to hold a substantial unit of beds in readiness for surges. And what we would try to do is have those regional surge hospitals designated and coordinated with the other hospitals in their region. So those would be the go-to hospitals. We have a COVID surge. It would be staffed with intensive care staff and others that would be able to manage a surge in COVID. At this point, they're focused on getting the first two of those up and running. And I can safely say that what we're looking at now is Eastern Shore, specifically the largest hospital there, Tidal Health Peninsula in Salisbury, and also Meritus in Hagerstown as a Western Maryland surge hospital. And we've had expressions of interest and discussions with other hospitals at this point. So we think after those two are finalized, they're trying to finalize all of the plans in place, which will include HSCRC. HSCRC will have some additional funding available to keep those surge units in the state of readiness. It's not a great expense, but it's something that we think was necessary to make this possible. And then also the formalization of their designation is also in process. So when those are finalized, would be coming back to you. Essentially, those would be new emergency CONs, like an emergency CON. You would give official recognition based on the endorsement of the Department of Health to designate these as surge hospitals. And if we had CON matters that came to us from those hospitals in the future, that would be something that we would take into account. They do play that role in their regions. But we're not ready to take action on any now, but that may be coming soon.
This staffing analysis come into your analysis of these facilities, in that, some of what I've heard in our Western Maryland area is that hospital capacity limitations are not physical plant limitations, it's staffing limitations.
No question about it. So we had 9,400 licensed beds in the spring of 2020. We knew that there was a lot of additional physical capacity beyond those licensed beds. And with emergency CONs, we added another 3,000 potential hospital beds. So there's bed capacity. That's not the big issue. The issue is that if we have significant surges, and we experienced this pandemic period, staffing is much tougher. That's clearly something that they're trying to address with this regional surge capacity hospital plan. I think the state is looking to actually play a direct role when there's a surge, and we're trying to implement a regional surge hospital plan. We would be assisting them in paying for and obtaining staffing through state contracts. Not the most popular plan for some of the hospitals. A lot of them would like a more flexible plan where they have their control of their own staff and bringing those on. I don't know how that's going to work out in the end, but the initial part of this plan is that the state is going to play a major role in bringing in contract staff when they need to at these regional surge hospitals.
I appreciate your sensitivity to, decentralizing high-level care in our state because it tends to coalesce around Baltimore. And in the more peripheral aspects of our state with lower population densities, the staffing does become, there's less people to draw staff from. So I appreciate your.
And admittedly, when you look at a place like Western Maryland, you can have a regional surge hospital in Hagerstown. You're talking big distances here. So I think people on the task force realize that we have to be mindful that you're not done if you just say, okay, this hospital in Western Maryland is our surge hospital. All the hospitals in Western Maryland have to have contingency plans. Because of the distances involved. This plan should work a little bit better in a place like Baltimore, where you have a concentration of both hospitals and staff population.
Thank you.
Thank you. So thank you all. Got a few minutes. I thought getting an update on the surge, next step of surge planning would be helpful. I expect that the November meeting will be pretty busy. There's a couple reports that are ripe for presentation that are required under legislation passed 2 years ago. We do have a CO, at least one CON planned for the November meeting. We have some regulations pertaining to advanced directives. The benchmarks for pre-authorization, I think I mentioned, there's renewed interest in not only the current regulations, and they're going to be slightly modified, but there's also some interest in providers, what legislative steps might be needed to further bolster pre-authorizations. We would, of course, only be considering the regulatory changes in pre-auth. The report I'm mentioning is the telehealth report, Senate Bill 3, House Bill 123, required state payers to continue the telehealth waivers that were established in 2020 to be continued through June of 2023. Our report is going to come up with recommendations on which ones should be continued beyond that time period, and which ones should be allowed to revert to pre-pandemic requirements. We also will talk to the commission and recommend adoption on the data submission regulations. At the outset, I talked about in this year, we'll have our data formats for the APCD, but we also expect to have a submission format for the non-claim-based payments that are required under our assessment of House Bill 1148, the Care First two-sided risk bill, and that will be incorporated in that presentation. We have 3 mandate studies that are underway. We're going to have to evaluate whether any of those three mandate studies, one on in vitro expanding the mandated benefit for in vitro fertilization, a second that provides a recommendation on whether physical therapy should be treated equivalently to primary care under the ACA. Copays were specifically controlled for primary care. There is a move afoot on the part of some providers to put physical therapy under the same broad definition as primary care. If any of you have gotten physical therapy or deliver physical therapy, you know that given that it's typically repeated treatments, it can become quite costly. And the providers think that it's more akin to primary and specialty care. And the last one is for coverage of at-take-home test kits for sexually transmitted infections. That's legislation that we are nearly ready for a recommendation on, but we want to be sure we understand how that those lab tests align with requirements of the ACA. So we'll keep you informed. We have to have those reports to the legislature by January. Given there's three of them, we're going to evaluate whether it makes sense to try to push one forward in November or present them as a bundle in December. I know this group of commissioners historically, back in the old days, mandates were a big business in the December commission meeting, but we haven't typically had a lot of them to consider. So it may be better that we roll them out slowly for your understanding of them moving forward. And lastly, much like some of the discussion today, the commission staff has been rolled into a variety of discussions on behavioral health. Some of them, we have budget language, which we are to evaluate the behavioral health crisis system in the state. That was inserted in budget language. That may not necessarily be exactly on point for what's needed, as legislation has been passed that moves that forward. Both Medicaid and the Behavioral Health Administration are making steps forward. But there are a host of issues related to behavioral health that we are either directly involved in or tangentially involved in that I think we want to wrap this up in a package and make sure the commissioners are aware of what the staff is being called to provide advice on. And that includes the development of a bed registry. David has been involved in that work. There's continuing work on residential treatment centers and the adequacy or inadequacy of that particular framework of care. And we've also been asked to weigh in on the adequacy of payment for behavioral health services in the state. I think a particular focus is on the differentials that exist in payment for behavioral health treatment in special psych hospitals, vis-a-vis community hospitals. As you know, maybe Commissioner Jordan remembers, psych hospitals are paid under Medicare PPS rules, whereas community hospitals are paid under the rate setting system that has historically been to the disadvantage of psych hospitals for Medicare services. These same hospitals, these psych hospitals, are paid state regulated rates for the commercial market, and Medicaid has historically always agreed to pay state rates, although they're not bound to for behavioral health treatment for care that's delivered at special psych hospitals. Two that come to mind are the small psych hospital in Anne Arundel County, and of course the much larger Shepherd Pratt. Certainly, there's greater awareness about the inequity of those payments as it relates to Medicare. But there may be very little that the state can do because that's set, those requirements are set by CMS. They've had opportunities to allow specialty psych hospitals to be fully rolled into the total cost of care to the state rate setting system, but have never allowed that to move forward with Medicare. So I'm not real confident about what the state can do, but I think it's important to understand that there are inequities in the system that do cause frustration on the part of the specialty psych hospitals and are worth everyone being aware of. So bundling up and as a project on everything that's going on with psychiatric care, which certainly is going to be a continuing debate in Annapolis too. There's a general recognition that in Maryland, much like the rest of the country, we're not doing as good a job on treating behavioral health conditions. Also wanted to note that David, Ken Yates Trotman, Craig Bem, now officially the president and CEO of CRISP, as well as Lisa Berry, who's executive director of the Civitas Trade Association of Health Information Exchanges, will be presenting at NATO next month, or actually next week, on building a health information exchange utility. The perspective from Maryland, it continues to be important to us to set a framework moving forward on how health information exchange and the development of a health information utility can really serve all stakeholders in Maryland, particularly in the area of public health. Maybe if there's time, I'll twist their arm and have them deliver it at lunch, a repeat performance.
I was going to say, will we be able to stream it or watch or see the presentation, or will you be giving us?
I think we have to have paid customers. We'll explore whether we can get a copy of that. And, if there's rotten fruit, I may forego that opportunity. But I do think we are being very proactive in looking for opportunities to make sure that the Maryland experience gets elevated across the country. So thank you very much.
Good luck with that, David and Ken. I'm sure it'll be fantastic. Look forward to it. Well, thank you very much, Ben, and to all the hardworking commission staff and to the commissioners. They're all eagerly leaning forward to see who's going to make this motion first. So do I have a motion to adjourn this public commission meeting? Commissioner Boyle, second. Commissioner Bazinski. All right, all in favor?
Aye.
Any opposed? Any opposed to going home? Okay, the ayes have it. Thank you very much.